Hi, let's talk about what causes hypokalemia. For better understanding, I suggest to watch this video on the physiology of potassium first. But let's start. What exactly is hypokalemia? Hypokalemia is defined as a serum potassium level below 3.6 milliequivalents per liter. Some sources use 3.5 as the cutoff, but the key point is when potassium drops below the normal range in the blood, we call it hypokalemia. Initially, this does not mean that there is a total loss of potassium in the body, which can be true in renal cases, for example, but sometimes potassium has just been shifted into cells via the sodium-potassium pump. Let's discuss the mechanisms of hypokalemia in this video. Why should we care about hypokalemia? Here's the critical thing to remember. The severity of symptoms does not always correlate with how low the potassium actually is. There can be a patient with mild hypokalemia who's very symptomatic, or someone with severe hypokalemia who feels fine. This makes it tricky and clinically important to understand and to always check for the underlying cause. Which organ systems are most affected by too little K+ in the blood? There are three main systems. It's the heart, muscles, and nerves. Let's break that down. In muscles, patients experience weakness, muscle pain, and cramps. And in severe cases below 2.5 milliequivalents per liter, you can even see muscle necrosis or rhabdomyolysis, which is the breakdown of muscle tissue. In the nervous system, with very severe hypokalemia below 2.0, an ascending paralysis can develop, potentially affecting respiratory function. But the heart is where it actually gets really dangerous. Hypokalemia can prolong the QT interval and cause arrhythmias, especially in patients with pre-existing heart disease like cardiac ischemia or heart failure. And then even mild hypokalemia increase arrhythmia risk in these patients very much. So what causes hypokalemia? Think of three main categories. First, decreased intake, meaning not getting enough potassium in the diet. Secondly, transcellular shift, where potassium moves from the extracellular to the intracellular space without actually leaving the body. And third, losses, where you're actually losing potassium from the body, either through the kidneys, which we then call renal losses, or through the GI tract, which we call extrarenal losses, so outside of the kidneys. Let's go through each one step by step. A decreased dietary intake is actually quite rare. The kidneys are really good at conserving potassium when intake is low. You really only see this in severe cases, like severe anorexia nervosa, where patients are starving. They are eating almost nothing for prolonged periods of time. Let's talk about transcellular shift, which is one of the most important categories. What causes potassium to shift into cells? There are hormone-dependent and hormone-independent mechanisms. Let's start with hormone-dependent shifts. So which hormones drive potassium into cells? There are three big ones: insulin, aldosterone, and epinephrine. They all stimulate the sodium-potassium pump, pushing more potassium intracellularly. When do we see this with insulin, for example? Here's a classic scenario. A diabetic patient receives insulin therapy. The insulin drives glucose and potassium into cells, potentially causing acute hypokalemia when a blood sample is drawn right after the injection. What about aldosterone? Aldosterone has a dual effect. Firstly, it stimulates the sodium-potassium pump. And secondly, it increases renal potassium excretion. We'll talk more about the renal effects later. You can see these effects in primary hyperaldosteronism, also called Conn syndrome, which is an aldosterone-secreting adrenal adenoma. But you can also see this in secondary hyperaldosteronism, like in renal artery stenosis, where the renin-angiotensin-aldosterone system, short RAS, is excessively activated. And then there's also pseudo-hyperaldosteronism, which refers to conditions that mimic aldosterone's effect, like consumption of too much licorice. What about epinephrine? Epinephrine also increases the sodium-potassium pump. How? By beta-adrenergic stimulation, which then drives potassium into the cells. And when does this happen? Think about situations with high catecholamine release. Physical stress, for example, in myocardial infarction or major trauma or shock, or even high-dose beta-agonist inhalation therapy during acute COPD or asthma exacerbation can stimulate this process. What about hormone-independent mechanisms? These involve rapid cellular uptake of potassium during new cell formation. So when those new cells are created in the blood in a very short amount of time. For example, after treatment of anemia. Too little vitamin B12, for instance, can cause megaloblastic anemia. And in the initial phase of treatment, there is so much substrate, so vitamin B12, available that the synthesis of new red blood cells gets stimulated very much. And as new red blood cells are rapidly produced, they consume potassium out of the blood. Another example is leukemia, which can cause pseudo-hypokalemia. Pseudo because it only appears in the sample. The abnormally high amount of white blood cells in leukemia in the test tube take up the potassium while proliferating, so the lab value is low, but the patient's actual serum potassium is normal. Lastly, there is the so-called refeeding syndrome. When severely malnourished patients start eating again, rapid cellular synthesis and metabolism increases again, which then also drives potassium on phosphate and magnesium into cells again. Now let's talk about losing potassium through the kidneys. What's the most common cause for this? It's diuretics, and especially thiazide diuretics, which increase the risk of hypokalemia significantly. Loop diuretics like furosemide can also cause it, but thiazides are usually worse. What about chronic kidney disease? Be aware, advanced CKD typically causes hyperkalemia, so a higher level of potassium in the blood, since it's kind of an active process to keep potassium in the body. When we talk about renal potassium losses, we're not talking about kidney damage per se, but rather conditions that increase urinary potassium excretion. But apart from diuretics who do this, which kidney disease, if not CKD, can cause hypokalemia? There are genetic conditions like Bartter and Gitelman syndrome. The presentation can be similar to the use of either loop diuretics in Bartter or thiazide diuretics in Gitelman syndrome. In these syndromes, ion channels are mutated, leading to a loss of function, similar to the use of diuretics. What else can cause hypokalemia from a renal point of view? Do you remember aldosterone? Initially, we said that aldosterone not only works on the sodium-potassium pump, but also on the kidney. How does that work? Aldosterone acts on the distal tubule and collecting duct to increase sodium reabsorption, to increase blood volume, but only in exchange for potassium. So with every gain of sodium into the blood, we lose one potassium ion into the urine. So all those aldosterone excess states we mentioned, like Conn syndrome and secondary hyperaldosteronism, they all cause renal potassium wasting. And then there's Cushing syndrome. In Cushing syndrome, there's excess cortisol in the body. Normally, there are special enzymes in the kidney which inactivate cortisol, so it doesn't bind to the mineralocorticoid receptor. But why? Aldosterone and cortisol are both steroid hormones, which look almost identical. So cortisol can actually bind to the receptor for aldosterone in the kidney. Or to be exact, there's actually just one receptor for both of them. So when cortisol levels are extremely high in Cushing syndrome, the enzyme gets overwhelmed. Cortisol then binds to the mineralocorticoid receptor and acts just like aldosterone, causing potassium wasting, leading to a drop of K+ in the blood. What about losing potassium outside the kidneys? Let's look at the disorders of the GI tract. Diarrhea seems straightforward, right? Diarrhea causes true potassium losses in the stool. The GI fluid can be rich in potassium, so with acute or chronic diarrhea, you lose significant amounts. But what about vomiting? Doesn't gastric fluid just contain chloride and protons, but little potassium? There's where it gets interesting. The pathomechanism of vomiting-induced hypokalemia is actually much more complex. Gastric juice is primarily hydrogen ions and chloride, so far so good, which together they form hydrochloric acid. When you vomit, you're not directly losing much potassium. So why does vomiting cause hypokalemia then? Here's the mechanism. You lose chloride, which is a strong anion, and this creates a hypochloremic state. Additionally, volume depletion happens, which activates the renin-angiotensin-aldosterone system due to low blood pressure as a result of the hypovolemia. The kidneys then try to reabsorb sodium and chloride to restore blood volume, but there is not much chloride available. So to maintain electroneutrality while reabsorbing sodium, in order to increase the blood volume, the kidney reabsorbs bicarbonate instead. This creates a metabolic alkalosis since bicarbonate is alkaline. And where's the potassium lost? As sodium is being reabsorbed in the distal tubule due to the RAS, potassium gets secreted into the urine to maintain electrical balance. And over time this leads to progressive potassium depletion. So vomiting actually causes renal potassium losses through a hypochloremic metabolic alkalosis with a normal anion gap, since the sum of chloride and bicarbonate in the blood remains the same. The same mechanism applies when you're suctioning gastric fluid through a nasogastric tube. So let's summarize. Hypokalemia can result from three different categories. Either from decreased intake, which is quite rare, and most importantly from transcellular shifts caused by hormones like insulin, aldosterone and epinephrine, or by rapid cell formation like in anemia treatment, or renal losses from diuretics, aldosterone excess, genetic tubular disorders like Gitelman and Bartter syndrome, and extrarenal losses with diarrhea and vomiting, causing indirect renal losses via hypochloremic alkalosis. Remember that symptoms don't always match severity, and cardiac patients are at highest risk for dangerous arrhythmias. So, thanks for watching, and I see you in the next video.